tetralogy, in when we were getting experienced, I'm talking about 25 years back, when the pulmonary arteries are small, when the Magoon's ratio is more than 1.5, you straight away go for intracardiac repair. If it is Magoon's ratio is less than 1 or 1.5, then we plan something called as palliative surgery, like putting a shunt. That means you get the blood supply directly into the lung. That means from the aorta, one of the branches of the aorta, you connect a tube into the pulmonary artery so that the blood directly goes into the lungs, gets oxygenated, comes back, so that the saturation level improves on the child. The cyanosis where the child appears blue is a little bit improved. Why you do this is because to make the child improve in the cyanosis, that is bluish discoloration slightly you make better, and then you also make the size of the arteries bigger so that it will facilitate for intracardiac repair after 3 or 4 years of palliative surgery. But nowadays with the Magoon's ratio, whatever age, after 4 months, Magoon's ratio is more than 1.5 or 1.8, you straight away do an intracardiac repair. What you do in intracardiac repair is, you resect the infundibulum is stenosed very tight, so you excise that muscle, make sure the valves are completely opened up, and then you close the VST with a patch. What we use generally is a PTFE patch, polytetrafluoroethylene patch we use, and then we cut open the pulmonary artery and the right ventricular outflow tract and put something called as a transannular patch, so that this is called as an intracardiac repair. This will give a definitive treatment for the children who have been operated on Tetralogy of Fallot. But only thing is, your Magoon's ratio should be more than 1.5 to have a good results. Once the Magoon's ratio is good, the intracardiac repair, the child can live for his complete life.